is the last one, right, for this month?
Yes.
All right, so this month we have respiratory. Guys from, let's see here, Wilmette put it out. Mike Lettieri, Ryan Menzies, and Kevin Schumann are the ones that put this together. So, and again, I apologize. I kind of talk more on one slide and skip over other slides. So as we go through it, I go through. So, oh, I got to read you a scenario.
She's sleeping.
All right, so you are dispatched to a person found down outside. Upon arriving on scene, your crew discovers an elderly female lying supine on the pavement beside a curb. She is breathing normally, and she is alert and oriented ×3, but finds difficulty in recalling what happened. Her GCS is calculated at 13. The initial assessment reveals the patient to have an injury to her head that has resulted in pooling blood on the pavement where she is laying. There is no other obvious injuries. A family bystander who witnessed the event states that the patient tripped and fell, striking the back of her head against the curb. Bystanders additionally state the patient lost consciousness for about 2 minutes. It was reported that the patient has a history of AFib, which she takes warfarin for. The patient denies any pain other than a headache. You apply a seat collar, transfer to the stretcher. As you treat the patient and continue your line of questioning while en route to the hospital, the patient stops responding, begins with snoring respirations at a rate of 8. Her GCS is now 9, and you note her pupils are unequal. What do you do now? What are some special considerations? And how will you secure her airway? So, what's your main concern with this patient here? What do you think? Well, she takes a blood thinner, and so she has possible head injury, so there might be some bleeding in the head. The unequal pupils, the snoring respirations, might indicate that, we have an increase in intracranial pressure. And so we want to make sure that we're going to first take care of any life threats, which would be her airway. Making sure that with a respiratory rate of 8, that we go ahead and ventilate. Maybe just a simple opening up with the jaw thrust for the airway to stop the snoring respirations. If you're a little bit aggressive, you might want to even consider our drug-assisted intubation. These patients, if they have an increase in intracranial pressure, it is best to get them intubated fairly soon. So let's just go straight to our drug assisted. I apologize, a lot of this is really small, so it may be difficult for you to see. So what are some of the indications for using drug assisted intubation? What types of situations? You can read what the indications are, but what situations would you want to use your drug assisted intubation? Increased ICP, head injury. How about anaphylaxis, smoke inhalation? Those might be some other types. So our protocol states that anytime that there may be airway or respiratory compromise, anytime that the GCS is less than 8, they have a ventilatory rate that is less than 10, greater than 40, or even if the patient's SpO2 is less than 92% on 100% oxygen. So those are definitely some of the times we would want to go ahead and get a little aggressive and get that airway secured. The other part of this protocol is that we have to take into consideration, I can't remember how old they said the patient was, but in our older patients, we have to be very cautious on the medications that we're actually going to give them. Why is that? Why are we so concerned with our elderly patients and giving medications? How about the fact that they don't metabolize them, or the metabolism has slowed down? They've got patients that might have chronic conditions. Depending if it's metabolized in the liver or the kidneys, that might make them toxic if it's too slow. So with our protocol, we actually state that if you're going to give some of these patients some of these medications, it's not a bad idea to call medical control and talk to the medical control about the dosages. All right, so we start off with pre-oxygenating our patients for 3 minutes. One of the things that, well, first of all, our students are going to start coming out to you guys here at the end of April. And one of the things, if you're in a situation where you might need to intubate a patient, that they are now being taught in class, and that is to put a nasal cannula on as you are pre-oxygenating and during the intubation process. A lot of recent studies on passive oxygenation that is saying that it is giving you guys more time to get the intubation done with the nasal cannula. Now, some of the reports are actually saying that in the nasal cannula at 15 liters, I haven't really bought into the 15 liters. I'll stick at 6 liters right now, but it's helping force oxygen down through the nasal pharynx, oral pharynx, down into the lungs while you're doing your intubation attempts. So you can put the nasal cannula on, and then you can start assisting your ventilations for 3 minutes while you're preparing all the rest of your equipment. One of the other things, if we have a patient with head injury, that we want to go ahead and administer lidocaine. Yes, that's still in our protocols. It's been a big point of discussion when we go over these protocols with the doctors, whether they want to keep the lidocaine in or not. Mainly it was said to go ahead and suppress the cough reflex, which would decrease, or actually it doesn't decrease, not increase is the word, intracranial pressure. And so the doctors say, well, it doesn't say it doesn't work and it doesn't say it does work, let's just keep it in there for right now in case it does work. So that's why we're keeping the lidocaine 1.5 milligrams per kilo. Want to make sure that you go ahead and administer that right away when you start your pre-oxygenation, so that it gives it some good time to work throughout the body. Then our next step is, once we're all set, we have all of our equipment ready to go, we're going to administer etomidate, 0.3 milligrams per kilo. Sometimes people will come back and will say, you know, the etomidate doesn't really work. And my question to them is, how long after you push the etomidate are you attempting your intubation? And it comes to find out that they push the etomidate and then they go ahead and get all their equipment ready. You want to have everything ready to go. Have the person that's going to be pushing the medications all set, have them push, you're ready to go with your intubation, and after about 15-20 seconds, go ahead and intubate the patient. Once you verify that tube placement is successful, go ahead and push your 2 milligrams of Versed right away. It does say for post-sedation, go ahead and use your Versed. And in this situation, we can go ahead and use a max of 20 milligrams of Versed for our patients. Whereas everywhere else in the protocol, Versed is only a max of 10 milligrams. The first line way to go ahead and verify tube placement now is capnography. Making sure you have a good waveform. Once you've verified, you can still go ahead and listen to lung sounds, listen to epigastric sounds, but you want to make sure that you are monitoring capnography readings before and after. You can even hook up your capnography to your bag valve mask also when you're assisting ventilations. Don't forget about the seat collar. The seat collar helps hold the patient's head in place in order to help stabilize the tube a little bit more. So our pediatric drug-assisted intubation protocol, very similar. We did remove the atropine on this last round, and I'm sure a lot of you remember that. We did remove that from the pediatric drug-assisted intubation protocol. I do know, and a lot of people have said, well, you know, other systems where I work, they still go ahead and use the atropine, and that's fine. It's just our doctors didn't feel the need to keep it in for whatever reason. Does anybody have any questions on the drug-assisted intubation protocol? Okay. So let's take a look at our respiratory anatomy. Our respiratory, we can actually break into the upper and the lower respiratory sections. And upper consists of the nasal and oral pharynx area, all the way to the point of the larynx. From there down, voice box, vocal cords, all the way down to the alveoli is our lower airway. But there's other parts that do make up part of the respiratory. Brainstem, pons, and the medulla also plays a very important part in our ventilatory status. our intercostal muscles and the accessory muscles, and even our diaphragm. With pediatric patients, and we take a look at these, they're not just little adults, they're not just small, there's a lot of different things that can affect their airway, unlike the adult. One is as big as the occipital lobe, a little bit bigger in these patients. So if you just lay them on a regular surface, the head is going to kind of collapse down that airway a little bit, making it a little bit difficult for them to go ahead and breathe. So you always want to make sure that you're going ahead and patting underneath the shoulders if you're going to intubate or even manage a child's airway. Some of the other thing, their tongue, it's bigger and it's floppier. Their epiglottis is a little bit bigger and floppier, so you have to manage that. And especially when we get into situations where there might be an allergic reaction and their tongue starts to swell, that mouth is so small compared to the tongue that it can be very difficult to intubate them. With the children too, the cricoid cartilage is the smaller area, so it comes down to like a funnel. As of an adult, it's pretty straight. So when they go ahead and they eat things or they put things in their mouth and they swallow them, everything kind of gets put into that tunnel and can get stuck a lot easier. So we start off with the brainstem when we talk about the respiratory center. And mostly the pons and the medulla are very important in controlling our respiratory, along with the baroreceptors and chemoreceptors within the body, which are all part of this. But these areas will help control our diaphragm and help control the accessory muscle use within our body. When we talk about, and I don't like to use the term respirations because there's a difference between ventilation and respiration. Ventilation is the actual physical breathing in and out, having the chest expand, having air run in or go in, and then the relaxation and air going out. Respiration is what we talk about gas exchange actually occurring down at the level of the alveoli. And so when we say, well, what's the respiratory rate of our patient? We really mean what is the ventilatory rate. Counting the respiratory rate is kind of impossible to go ahead and do. So we have our voluntary ventilation, meaning that when we need to go ahead and sing, scream, holler, even talk, we can go ahead and that's all part of the cerebrum, and that's going to send an impulse to our pons and medulla to go ahead and assist in that. Voluntary respirations is we don't think about us breathing or ventilations. We don't think about it. It just goes ahead and happens based on those baroreceptors, chemoreceptors. Now remember, mostly our ventilations and respirations are controlled by the CO2 levels. Our body goes ahead and recognizes, hey, we have too much CO2 in our system. We need to go ahead and breathe a little bit faster. Certain other medical conditions such as COPD mainly will take a look, and they have very high levels of CO2 in their system, and their bodies get used to it. And so sometimes they look at the hypoxic drive or the O2 levels. I mean, also pH can go ahead and have effect in it too. When our pH gets a little bit acidotic, it can cause our respiratory to go ahead and breathe a little bit faster as a way to make ourselves respiratory alkalosis, so we can go ahead and start to blow off some of the excess acid within the body to try and bring back homeostasis. Our cranial nerves are also responsible for respirations. Cranial nerves number 5, 9, and 10. And that also transmits information to our brainstem to help us go ahead and assist in our ventilatory. Some of the other things, it's kind of like with the heart, but as the lungs fill up and get bigger, the stretch in them, the body says, okay, we've stretched enough, you can go ahead, and it stops the inhalation, and then we can start our exhalation process. Now, trauma can play a big part in our brainstem function in itself. We start talking about increased intracranial pressure, and one of the things we see with increased intracranial pressure is Cushing's triad. We have the blood pressure that goes up, heart rate has a tendency to go down, and then respirations become irregular. Usually we have the Shane-Stokes type respirations. There's a couple different types of brainstem herniation. One, where you can have the bleed or the damage in the front and it pushes the brain back and down. You can also have it on the side on the temporal area, which will go ahead and push the brain sideways, so right where the foramen magnum and the brainstem goes down into the spinal cord, it can start to go ahead and compress that brainstem. And then at the level down here, you can start to see some of it can push straight down and have some of the brainstem start to go out of that foramen magnum right along with the brainstem herniation. One of the very first things too that we see based on where the cranial nerves are, that the third cranial nerve is right by that, third cranial nerve. Right by there where you're going to start to see unequal pupils is one of the very first signs and symptoms of increased intracranial pressure. Now, other than trauma, some of the other things that will affect our brainstem function is a stroke. And again, that's more looking like our hemorrhagic strokes. We see the increased intracranial pressure. Metabolic acidosis, secondary to diabetes. Even the different drugs and alcohol a patient may take can affect our brainstem. Different environmental issues, if they're too hot, too cold. And it's not just environmental with heat, but it also can be the fact that someone has a fever. Hypoxia. Hypoxia, one of the very first signs and symptoms of a patient not getting enough oxygen to the brain is altered mental status. And so talking to a patient and having them, seeing if they're able to answer questions over and over for us, again, is a good indicator if a patient is getting enough blood to their brains. So with our upper airway, we have the nasal passages in the mouth that bring air in. The main part of the upper airway is to go ahead and warm and filter and humidify some of that oxygen, kind of clean it up a little bit before it makes its way down into our lungs. Some of the things that will affect the upper airway, trauma to the face. If someone ends up having damage to the nasal passages or the mouth, we might have some damage, you can't actually get air in. If a patient has a foreign body airway obstruction, they've swallowed something, it's occluding the airway. Environmental changes, if they have edema, angioedema, swelling from an allergic reaction, or some other type of toxin, superheated air, cyanide poisoning. Those are all different things that can affect the upper airway. Now our lower airway structure starts at our vocal cords or larynx, and it goes all the way down to our alveoli. It goes down the trachea, right and left main stem, through the bronchioles, bronchiolus, all the way down to the alveoli. So once we get down to the alveoli, this is where gas exchange actually occurs. When we go ahead and we breathe air in, oxygen goes across into the alveolar capillaries and goes to the rest of the body. Also at the alveolar capillary level, CO2 gets offloaded into the alveoli and we will go ahead and exhale that out. Now you have to remember, in the upper part here, from the mouth down to maybe about the bronchial area or the bronchi, gas exchange doesn't occur in those areas. So when we start our exhalation, there's about 150 milliliters of air that does not actually have gas exchange occurring. Remember, our tidal volume in our patients is about 5 to 6 mLs per kilo. Normal standard adults, anywhere from 5 to 700 mLs of air. When we have people, when we're doing real good with oxygen and gas exchange, there's other problems that can occur that can get in the way of that gas exchange. When we talk about ventilation, somewhere that you have an obstruction, you're not getting the air in. You have patients that have emphysema, bronchitis, you've got mucus that might be in the area of the alveoli, and gas exchange can't occur. Other things though we see with this mismatch is perfusion problems. Even though we're getting oxygen into our alveoli, we might not have great blood flow. And so if there's not hemoglobin carrying able to carry oxygen away, or the blood is not able to return back to certain areas to go ahead and offload the CO2, these patients a lot of times can go ahead and become respiratory acidotic. Some things like tension pneumos, PEs, tamponades, hypovolemia are different things that can cause VQ mismatches in these patients. Yeah, and these are exactly some of the things that we had just talked about there. Now, other problems too that'll affect ventilations is our spinal cord. And each one of our spinal cord nerves will affect a certain area of our respiratory tract. When we look at C1 through C3, this works on the accessory muscles in the neck. C3 through C5 in the diaphragm. And then our thoracic work on the abdominal muscles and our intercostal muscles. Without the ability to go ahead as we have the diaphragm pulled down and the intercostal muscles to pull the thoracic cavity out and upward to make it bigger, air will have a difficult time moving in. And then when we relax, all those muscles will relax, and then when we start the exhalation process. All right, so when we have patients that have difficulty breathing, it's really important that we take a look at what is or why is our patient having that difficulty breathing. We can take a look and say, oh yeah, they've got wheezes, they've got rales, they've got rhonchi, they've got a history of COPD, emphysema, asthma, whatever it is. We can take a look and see that information, but why today are they having the difficulty breathing? And if we follow that, we should be able to kind of weed through what our appropriate treatment should be for them. Getting a good past medical history. What medications are they on? Are they taking cardiac medications or are they taking respiratory medications? Are they allergic to something? Maybe something environmental. Have they had surgery where they've had a lobe of their lungs actually removed? Taking a look at the chest. Does it rise and fall equal bilaterally? Does it have paradoxal movement? We don't really use percussion pre-hospital. I do know there are some that like to do that, but for the most part, most of us don't. But the other main thing we need to make sure we're doing is listening to lung sounds. So we have many different types of breathing patterns, and we're going to take a look at some of these here. Kussmaul respirations, why I'm pulling this up. Kussmaul respirations is something we see with metabolic acidosis, diabetic ketoacidosis, those that are in renal failure, someone that has, okay, take a look at this child's chest. This is Kussmaul respirations. They're deep ventilations and they're quite rapid. And he's trying to get enough oxygen in and trying to blow off some of that excess CO2. Now with these patients, you're going to, if you put the capnography on them, your capnography reading is probably going to be in the low 20s, which is acceptable. And that's one of the things we tell you, that with these patients, diabetic patients, to use your capnography, and it will help make the determination if someone is actually in diabetic ketoacidosis. But you can see the nice deep ventilations. Shane-Stokes ventilations. We see this with different types of brainstem issues, concerns. Increased intracranial pressure is one of them. And this one can be difficult to go ahead and determine from BIAT. So if you take a look here, we've got slow respirations, and then he goes into a little bit quicker of a respiration. And then he actually goes back down into a slower respiration. Not uncommon to see this in someone with heart failure or increased intracranial pressure. And then BIATS or BIATS or whatever however anybody wants to pronounce it. This is very common to see in kids that have meningitis or have increased intracranial pressure also. This is quick ventilations followed by periods of apnea for about 20 seconds. So you can see the quick ventilation, and then we have a period of apnea where nothing's going on. And then again, we quicken up again, and then down to nothing. So when we listen to lung sounds, honestly, this is a little over excessive for what we do, but we have 5 lobes. We should be listening anteriorly and posteriorly, and listening up against the skin. When you use your stethoscope, the diaphragm portion needs to be what's up against the skin. Don't use the bell. The bell is mainly used for heart tones, if you're going to listen to heart tones. But anteriorly, listening, you know, on the upper of each lobe, and then work your way down. 6 on the front, 6 on the back, and then listening mid-axillary also is very helpful, right underneath the armpits. But yeah, this is a little bit too much. A lot of times when you ask your patients to take a deep breath in, you want to make sure that they're exhaling through their mouth when they breathe. It just helps with hearing some of the lung sounds. Quite a few different lung sounds as we listen to them, but mainly we're listening for wheezes. We're listening for crackles, or otherwise known as rails, rhonchi, or stridor. So, a normal breath sound. When you listen to a normal breath sound, the inspiratory phase is a little bit longer, and you don't really hear that gap.
Her pharmacist consulted with her.
I'm going to go to the part where you can actually hear the lung sound. Nice, clear breath sound. Some of the abnormal breath sounds, if you're listening bronchial, higher pitch count sounds, your inspiratory, expiratory phase is about the same. Still sounds pretty clear. And then we have our adventitious lung sounds. These are lung sounds that usually indicate something might be going on. Wheezes. We hear wheezes and we think, oh, asthma right off the bat. We hear crackles or rails. We think heart failure. And so this chart breaks it down actually pretty good, but again, it comes down to what's really going on with the patient. So rails or crackles usually indicate fluid in the alveoli, usually in the lower bases. And we hear that fine kind of popping sound. This is usually heard in patients who have CHF, and it can be heard in patients with pneumonia. Rhonchi is usually heard in the upper airways, the larger airways. And it sounds more mucousy, someone has bronchitis. Not uncommon to hear in someone with COPD, especially the bronchitis. And then even our pneumonia patients. Wheezing, we think asthma patients. But this is when we have the bronchioles that are actually constricting or have a lot of mucus that are making the airways a little bit smaller. Bronchitis can be heard, asthma, and we can hear it in pneumonia patients as well, or patients who have heart failure. And then our stridor, usually it's over the tracheal area, the upper airway, usually indicates some foreign body or somewhere where it's actually closed that airway up at that point. So let's listen to some wheezing sounds here. Now,
the opioid my doctor prescribed for my chronic back pain.
On the expiratory, we hear the wheezes. Breath out. This one's a little bit better. So this is where you're hearing, mainly the bronchioles are closing down. We've got to go ahead and open those up a little bit. And we'll talk about some of the treatments here in a minute. Now crackles, based on the lower airways, they can be fine or coarse. We hear it in heart failure patients. Inhale, exhale. You usually hear it on the inhalation phase. Hear that finer, and there's actually some wheeze in there on the exhalation. You okay?
Yeah, good.
Okay.
Yeah, I caught you, thank you. Thanks for being nice, I caught you.
And then we have stridor. This is common in kids and infants.
Wait.
Yeah, so with those, remember with children too, they usually will grunt when they're having a hard time breathing just because they're trying to maintain a higher level of PEEP and keeping those lower airways open. Now, pleural rub, this is actually very difficult to go ahead and pick out and hear. We see a pleural rub happen usually after someone has pneumonia. You have the visceral pleural, which lines the organs, and you have the parietal pleural, which lines the cavities. And there's a thin layer of fluid in there that when those organs move, they just slide right over that parietal pleura. But when that area dries up, usually when someone has pleurisy, you might hear something like this. People have described it as leather type sounding. I don't know. To me, I have a hard time with it. Yeah, it's just a little bit more difficult. All right, so let's start with our pulmonary edema protocol. So you have a patient who you get there and it's 5 o'clock in the morning when you get the call. They're sitting up on the edge of the bed, feet dangling over, hands on the side, kind of in that tripod position almost. As you walk in, you can literally hear them drowning in their own fluid. You can hear the fluid or the crackles audibly. But you also, let's say you hear some wheezes. First of all, with our heart failure patients or our pulmonary edema patients, they usually have a tendency to have a little bit higher of a blood pressure. Not uncommon to see like 190 over 110, 120, somewhere right around in there. Okay? And so with these patients, we want to give them a nitro. Nitro, remember, is going to cause vasodilation, but it's also going to help reduce some of the pulmonary pressure within the lungs and help the blood to start flowing, flowing a little bit better. We will see with these patients maybe even some pink frothy sputum. Because of the pressure so high in the lung, the serum from the blood itself leaks over into the alveoli. So when they start coughing, it's kind of that foamy, pinkish color that they'll be coughing up. Normally, they don't have a real productive cough unless they're coughing up the pink, frothy sputum. We want to make sure that we're getting CPAP on these patients as soon as possible. So you're in the house, you bring in your airway kit, you bring in your medication kit, you give them a nitro, and then get the CPAP on them as soon as possible. CPAP is going to help push some of that fluid out of the alveoli back into the interstitial and vascular space. We start off with a PEEP of 5. Generally, a PEEP of 5 is fine for patients with bronchial swelling of the bronchioles. And then we try and get them to a PEEP of 10 if we can with our pulmonary edema or COPD patients. It's going to keep the alveoli open and allow more oxygen or ventilation oxygen and exchange to occur. Make sure you're giving these patients a nitro every 5 minutes. You want to go ahead and keep reducing, if you can, the pulmonary pressures within the lungs. So if you do it in the house, by the time you get out to the rig, they should be ready for another nitro. As you're pulling into the hospital, it doesn't hurt to go ahead and give them another nitro if you're at about your 3 to 5 minutes. We can only give a max of 3 nitro at this time. Now, as far as the Lasix is concerned, just be very cautious. Don't automatically just give them Lasix because they're in heart failure. Take a look at the patient yourself. Most of these patients are elderly patients and they're on some diuretic already. And if they're on some diuretic already, they're probably, maybe it's a non-potassium sparing diuretic, but a lot of them are already dehydrated. By giving them more Lasix, you can further dehydrate them. So just be really cautious when you're using Lasix for these patients. I know it's in there, but just watch it a little bit. Let's go back to our guy here that we saw, or came in and he was sitting on the bed and you heard wheezes. Now, do not give these patients albuterol and Atropine just because you hear wheezes. Think about what's going on here. Remember, with patients who we hear wheezing, it's the bronchioles, they're closing up, a lot of mucus production. So the albuterol and Atropine is going to bronchodilate, help the air get through a little bit better. But in situations where we have an increase in our pulmonary pressure, the bronchioles are actually smushed because the pressure is so high. And Atrovent and albuterol is not going to do anything for those patients. The other thing is, why are they in the pulmonary edema? Most of them are in pulmonary edema because their heart is starting to fail. And so if we give them albuterol and Atrovent, it's just going to make the heart work harder. And that's the last thing we need to do, is increase the oxygen demand of that heart. Make it already work harder than it is, and it can have a tendency to fail. So really think about what you're doing with these patients. Don't just say, well, I heard wheezes, I give albuterol and Atrovent. Have a reason of why you're giving it. And remember how it works before you just automatically throw it in there. Now with our unstable patients, this really kind of falls into our cardiogenic shock protocol. Blood pressure less than 90 systolic. The left heart is starting to fail, or has gone to the point where it's failing. And it's decreasing our cardiac output. And we also have a decrease in our preload for these patients. Not enough blood is getting back to the heart. We want to refer back to our cardiogenic shock protocol. We give them dopamine. Remember, dopamine has that inotropic effect, which will increase cardiac contractility, hopefully going ahead and raising the blood pressure a little bit. Remember, dopamine has a couple different levels. At very low dosages, it's like 2 to 8 mics, it helps with renal perfusion, helps them go ahead and get more blood flow to the kidneys so that it can be filtered and the kidneys can do what they need to do. At 5 to 15, inotropic, and even at higher levels, we can have the vasopressor type of effect with them. Okay. So we go on to that. We obviously want to not use our CPAP. Remember, with CPAP, we don't use it on patients if their blood pressure is less than 90 systolic, if they can't follow directions, if they can't maintain their own airway. Remember also, CPAP will go ahead and decrease the preload back to the heart. And so we've got to watch their blood pressure, manage it very closely if you're using your CPAP. Any questions on pulmonary edema? Does anybody have any questions about your CPAP itself and how you use it? Or it's pretty, I mean, I like the new ones that we have, the flow safe. Just remember, if you're using the CPAP for your Your asthma patients or COPD patients, you want to make sure that you have a nebulizer set up with it, just because of the fact that they can get air in, but they can't get air out. You can get some of that medication in, it'll start working, causing some bronchodilation, and they'll be able to breathe a little bit easier. All right, our asthma COPD protocol with wheezing. I hate this protocol. I just don't like the way it's written. Routine medical care, buterol and adjuvant. Doesn't work, give them another buterol adjuvant. Doesn't work, give them another just buterol. And if that doesn't work, then we can go on to epi. This is where you guys got to be smart about it. If you walk into a patient who's having an asthma attack and they've had some of their own buterol and adjuvant, or you know that they're not in a good way at this point in time, it doesn't hurt to go ahead and start the buterol and adjuvant and have someone get on the phone and ask for the epi. Now, some of the questions the doctors are going to want to know before they give you the order for the epi, especially in our adults, is, are they over the age of 40? Do they have a cardiac history? And why are they tachycardic? A lot of times we can go ahead and answer the tachycardia with the fact that they can't breathe, so that's why they're tachycardic. But they look at 40 that sometimes they have an undiagnosed cardiac history. They don't like to go ahead and give epinephrine to someone that does have a cardiac history. There's other medications such as terbutaline that they can go ahead and use that does exactly the same thing, but doesn't have the alpha effects like what the epinephrine does. So make sure you're prepared to answer some of those questions for those patients. Have they ever been intubated before is also another good question that you want to ask. If they have a tendency to deteriorate rather rapidly. But just don't think you automatically have to go ahead and do all three of those steps before you get to the epi. Do what's in the best interest of your patient. Take a look and really assess your patient. Use your protocol to your benefit to actually treat the patient appropriately. With your COPD patients, you can contact medical control to use the CPAP. Again, let them know you want to get your neb set up. And again, are they tachycardic? You know, what are the lung sounds that you're hearing for these patients? So with our COPD patient, mostly it's an inflammation problem. They've lost the elasticity of the lungs. They've got that big barreled chest. And so their bronchial, they're kind of starting to harden up a little bit. And gas exchange a lot of times can be ineffective with them. The bronchioles also a tendency to collapse. They can't actually use that PEEP to go ahead and keep some of those airways open. So we've gone through our treatments for them again, oxygen, duo-neb, epi if they're in severe distress, and then CPAP also. And if it comes down to it, we have to intubate, we would go ahead and use our drug-assisted intubation. Our asthma patients, bronchial constriction or bronchospasms, and this is where we go ahead and we use our buterol and adjuvant. Now, with them, yes, you might hear wheezes, but be more concerned if you're not hearing anything. You can't hear any air movement. That means everything is clamped down so tight that you know, getting air in is going to be very difficult. Just to bring up here too, we have the ability to give magnesium sulfate for our children asthmatics. We do not use it for the adults. Our doctors have done lots of studies and realized that it doesn't always work on adults. However, in our ERs, it's a lot of times with someone who's got extreme issues with asthma, they will go ahead. So one of the first things that they do in the hospital is they do go ahead and give them mag sulfate. Would you be wrong if you had a patient who was an asthmatic and nothing you were doing was helping them, and you asked to go ahead and give mag sulfate for the adults? Absolutely not. The worst they can say is no if it comes down to it. But I know you guys are rather close to the hospitals, and that by the time you would actually get to that, you'd almost be there. But If it's a bad enough situation, you have a delay in your transport, it's not outside the spectrum for you to go ahead and ask for. With children, our dose is 25 milligrams per kilo in 100 cc's of D5W or normal saline, and you run it in over 15 minutes. Here is our pediatric and our croup protocol. Now, the difference between croup and epiglottitis and croup, the difference between your epiglottitis and croup. Your epiglottitis patients, they're sick. They look like they're sick. They're probably pretty lethargic. They may be drooling. They don't really make contact with you. We see this in the older kids, and don't just dismiss the older kids too, but also we've been seeing quite a few adults end up with epiglottitis as of late. They are vaccinated for it, but you know some kids don't always get their vaccinations. Croup, a lot of times we see this with the kids about 2 years of age, and mostly they have their fits at night or after some type of activity. So even if it's in the afternoon and they've been playing a lot, they may end up with that barky type cough. So if they're stable, we just go ahead and give them humidified oxygen. See how they do. If we suspect wheezing and they're having a hard time breathing, we can give an albuterol and adjuvant treatment. Again, we can go down the line 3 times. If no improvement, another one. If no improvement, just albuterol. But if you really feel this kid is just not progressing like you want him to, we have the ability to nebulize our epinephrine, and we'll go through the dosing of that in just a moment. If the kid is unstable with the croup, you might need to assist ventilations, give them some oxygen, bag in the albuterol treatments, use your inline. You can use it with a bag valve mask, not just an ET tube. You could, if you needed to, intubate, but only times 1. And again, work your way down with the albuterol and adjuvant. You can also bag in the nebulized epi if it comes down to where you need to intubate and you feel the need to give epi instead. You can actually bag that in. So our dosing for the new dosing for the epinephrine, if they are less than 5 kilos, we know our standard protocol, and that is always contact medical control to ask for dosing. If they are 6 kilos, you're going to put 3 milligrams or 3 mLs into a nebulizer chamber and add 2 additional mLs of normal saline. If they are 8 kilos, you're going to use 4 epi 1 to 1000s and add 1 ml. And if they're over 10 kilos, it's going to be 5 epi 1 to 1000s with no saline. Most of the time with the croup patients, they're pretty interactive with you. You pick them up in the middle of the night, they sound terrible in the house, you get them outside, halfway to the hospital, the kid's fine. You're like, okay, I just told the hospital the kid doesn't look very good, but now they seem to be fine. And that's what we see. Once they get that burst of cold, humidified air, it has a tendency to kind of settle things down and decrease some of the swelling. With our epiglottitis patients, give them humidified saline or humidified oxygen with some saline. If they're not improving, go straight to your nebulized epinephrine. And again, we don't want to go ahead and agitate these children. Keep them as calm as you can. If they want mom, and go ahead and have mom be right there with them if you can, but you want to make sure these children stay as calm as possible. You don't want to agitate them. Oops. If it comes down to the point with these kids that we cannot get an airway, we may have to resort to our quick trachs. The 4.0 quick trach is used for anybody greater than 76 pounds or 35 kilos. The 2.0 is 22 pounds or 10 kilos up to 77 pounds, 35 kilos. Anybody in 22 pounds, we're going to go ahead and use our needle cricks. But remember, a needle crick can be used on anybody if necessary. Has anybody had the opportunity to use a quick trach? Chance? A lot of people think, oh, they're going to slide right in like butter. They don't. They do take a little bit of effort. When you're entering at the cricothyroid membrane at a 90-degree angle there, you're going to need a little bit of oomph to push that needle through. Okay? Just be careful that you're not pushing too hard that you go right through. But make sure that little red stopper's on there so it'll stop you also. All right, anaphylaxis. We have 3 different patterns. If you have someone who just has an allergic reaction to something, they have hives, wheals, a little bit of a rash, they got stung by a bee and it's red and swollen, and they want you to take them into the hospital, that's fine. We can go ahead and give them Benadryl, 25 milligrams. With this patient, I don't even think I would start an IV. I'd probably give them the Benadryl IM and give them maybe an ice pack or something like that to put over the area where it seems to be hurting if they were stung by a bee. With the allergic reaction with airway involvement, these patients, we want to go ahead and administer epi. Epi is going to help with the alpha and beta, or the beta effects that it uses with bronchodilation. And we give now 0.5 milligrams IM. And we're going to repeat that every 5 minutes, so we need to make sure we're monitoring them very closely. If the patient is wheezing, we can administer an albuterol and Atrovent. And then here we can also give 50 milligrams of Benadryl. If you choose to start an IV on this patient, that's fine. You can give the Benadryl IV also, but just make sure you're giving it slow IV push. Now the difference between the allergic reaction with airway involvement and anaphylaxis is a systemic response, meaning that it's affecting 5 or more body parts or body systems. Blood pressure is going to be low. Vasodilation is going to occur. The histamines within the body are going to cause an increase in gastric mobility, the H2, and then obviously we have the H1, which cause bronchial constriction. We want to go ahead, it says secure the airway first, and this is going to be a 2-person job. One of you is going to be working on getting that airway. And it's a really good idea with these patients to get a secured airway like an intubation. King tubes, not so much, because we want to make sure we're passing down through the glottic opening, so in case that swells, it doesn't close up. And then give the epi. Epi is going to be the big thing that this patient's going to need, and it's going to be 0.5 milligrams IM every 3 to 5 minutes. Push your Benadryl. That will help with the H1 receptors. We don't give anything for H2 receptors. They'll give them Tagamet or something to that degree at the hospital. If we hear them wheezing and you've got them intubated, bag in an albuterol Atrovent treatment or a duonep treatment. Now this patient really is, his blood pressure is really plummeting. He's not doing well at all. You've given him a couple fluid boluses and things aren't going like you expected. You can contact medical control to administer 0.5 milligrams of epi 1 to 10,000, and this will be pushed IV. Remember, don't push the epi 1 to 1,000 IM or IV. You'll end up seeing Dr. E if you do that. So. Our pediatric asthma follows the same guidelines, just again, just different dosing. 0.01 milligrams per kilo is our dose of epi for these patients. Refer back to the back of your book, your protocol book, to make sure that you are administering the proper medications. You know, use your map to make sure that someone is double checking your medications. We had a situation that we had a patient or a crew push 1 full milligram of epi 1 to 1,000 on a 6-month-old. So we want to make sure that we're giving the proper amounts. All right, other respiratory, tension pneumo. What is the difference between a simple pneumo and a tension pneumo? Hypotension, JVD, tracheal deviation, things like that. Patients, well, they're both going to have decreased breath sounds, or could have decreased breath sounds on one side. They might be tachycardic, they might be breathing a little bit faster, but the real difference between the tension and just a regular pneumothorax is the fact that they're hypotensive. JVD, tracheal deviation, those are late signs. Probably not something that you're going to see out in the field, if it happens fairly closely, it's going to take a little bit for that to actually occur. So how we go ahead and we fix this, we give them oxygen, and then we perform a needle crimp. Now make sure you're using your kits. You don't want to pull a 14 gauge out of your IV catheter stuff and just use 1.5 inches. You need the 2.5 inch catheter in order to perform this skill. You're going to go in between the second and third ribs, and you want to go over the top of the ribs. If you go underneath, that's where all the vasculature is and all the nerves are. You want to stay away from that. We don't use flapper valves anymore. We don't use the tips of the glove. Basically, you're making it an open pneumo so that air is going to rush out, and as the lung goes ahead and expands, that catheter kind of folds up and it occludes itself off. So no need to worry about it, no need to take it out. If you have the need to go ahead and do another one, depending on which side you're on, just be very careful that you're not going too close, that you're coming anywhere near that heart. And that's the last thing you need to go ahead and do. But you can go ahead and, I usually will go one more down mid-clavicular at that point and go between the third and the fourth rib to go ahead and insert another needle. Don't remove the first one, the birth catheter, just go ahead and leave it alone. It will be fine. Anybody have any questions on needle decompression? Capnography, we've been talking about it for years, but we have really made it mandatory now. It is, anytime you intubate a patient, you have to have capnography. You have to verify your tube placement with that. You have to monitor. Anybody with difficulty breathing, diabetes, seizures, trauma, sepsis, cardiac arrest, you want to make sure that you are using your capnography for these patients. Normal capnography is 35 to 45. We want to take a look and not only see what the waveform looks like, but what the numbers are telling us also. So you can see with this first one here, the obstruction, the bronchospasms. A lot of people say it looks like a shark fin. Doesn't look as nice as that on a real one. But we have bronchospasms. They're trying to push the air out, which is why you have that delayed upstroke with these patients. You see that these patients need some type of bronchodilators. They want to get albuterol and Atrovent to them. We have a cleft palate or a cleft plateau. That can indicate a couple different things. You've got your patient and they are intubated. They might be starting to fight the tube a little bit. Indication to go ahead and give more Versed to them. Could also indicate that they might have a pulmonary emboli. Put that together with signs and symptoms and your 12 lead, and you can kind of come up with a good field diagnosis. If you're doing CPR, no, we are not aiming for 10 unless we're trying to kill our people. We want to see at least 20, 24, right around there with your end tidal for good solid CPR. If they have an end tidal of 10 or less, that is a good indication that we should withdraw resuscitative efforts. There hasn't been one study done that anybody has survived a cardiac arrest with an end tidal less than 10. Patients that have high levels, greater than 45, they're either hypoventilation or they are metabolic. They're metabolically alkalotic. Yeah, have things sometimes here. We want to assist their ventilations, breathe a little bit faster for them. Okay. Hyperventilation, something less than 35. We want to slow down the breathing for them. Usually might indicate that they are metabolically acidotic also. It's a good indication when you have someone intubated that you're using it, because if we have the loss of the waveform, it means something happened with your tube. And you can use your DOTE pneumatic to go ahead and fix it. Did my tube become displaced? Is there obstruction to the tube, a mucus plug on the end? Did the patient develop a pneumo? Or is there some type of equipment failure that I need to look at?